And thanks to Tanna sir for allowing us to conduct this meeting in his absentia. He is traveling and hence he will not be joining today. We'll be having a wonderful discussion on philosophy of fixation in intertrochanteric fracture. And as we have a lot of fixation modalities available, I remember when I was a resident, there was only one thing, and that was a Jewett nail plate. And then during our residency and registrarship came the DHS. And that was a great revolution when the DHS came and we thought we have conquered. And then over a period of decade, we realized DHS has problems. And of course, angle blade plate was also there at that time, but was uh, available to very few select institute during 70s, 80s, and 90s. And then came a lot of other devices. And when the PFN came, we thought there is a revolution. And only to realize that there are problems with PFN as well. So today is discussion on intertrochanteric fracture, philosophy of various devices and their description. Welcome, Dr. Gadegone.
Sir, good evening. How are you?
All good, sir. All good.
So
All good.
we'll discuss today only the rationale of just introduction of the implant and rationale of use of these implants.
Yes. So,
Whether it is
absolutely. That's a wonderful thing to discuss because when a patient comes, within a minute or two in our chamber, we have to give them what we are using. Are we going to use a rod, a nail, or a plate, or a combo? So we have to opine very decisively to our patient. And if our rationale is very crystallized in mind, I think it becomes very easy to offer them what we want in this particular case. And there are plethora of presentation on varieties and sub-varieties of intertrochanteric fractures. So none other than Dr. Gadegone is going to take us through the philosophy of all this. So can you share your screen, sir?
Yes, sir. I will share my screen.
Yeah.
And it's a very interesting topic. So are you able to see my screen, sir?
Yes. Before beginning, if there are any views or any comments from anyone who has joined already and any particular thing you would like to get emphasized, just let us know. Please proceed, sir. So you're talking on implants in IT, fracture femur and their indications.
This rationale, indications and rationale.
And their rationale. Yes.
Okay.
So when you start started practice, I suppose you all started, you had your time started with JNP?
I have all described it in this implants, what implants and what is
Please proceed.
And why there is evolution of the implants are there. So this is a very comprehensive lecture which lasts about a half an hour, and it will combine both intramedullary as well as the extramedullary implant. More emphasis on implications and why they should be used and why they are. So this is the always a debate. You can see here. Okay. Conductor, my slides are not moving. What is the problem? Just moving. So now I will start, sir. Okay. So debate over the best implant continues, whether to use intramedullary implants or extramedullary implants. And there is always a dilemma in mind when the patient comes of an intertrochanteric fracture, and they are usually old osteoporotic people. So proximal femoral fracture accounts for a large proportion of hospitalization among trauma cases. And overwhelming majority of these patients are aged above 50 years. The incidence of this fracture is 2 to 3 times more in females as compared to the male. An intertrochanteric fracture occurs between the greater trochanter, where the gluteus, medius, and minimus muscle and extensor attach, and the lesser trochanter, where the iliopsoas muscle is attached. So this is the area where we see the intertrochanteric fracture, and below the lesser trochanter is a high subtrochanteric fracture, and below that 5 centimeter we call it as a within 5 centimeter subtrochanteric fracture. These are all you know, these are all basic. But the most important is the classification, which helps in the choice of implant and prognosis. So AO has classified into a 31A1, 31A2, and 31A3. So this is a single part, two-part fracture, and this is with the lateral wall, we can say with the three-part fracture, and lateral wall is intact, and it is more than 20 millimeter, I suppose. So when you call it as a, these are all A1 and A2 call it as a stable fracture, whereas A3 fracture is called as a relatively unstable fracture, depending on the thickness of the lateral wall and the involvement of the lesser trochanter. But nowadays, with the advent of a CT scan, it has been proved beyond doubt that the what we were called as a two-part fracture, always it turned out to be a three-part fracture, and CT has revised the classification now. Probably on the X-ray picture, it looks A2, so it may be A3, A31, A3 fracture or something else, and therefore it should be a 31A to be called as a stable or unstable, depends on the CT scan picture. But the most important we can see here, A23 fracture where lateral wall is involved, and you can see how a thin wall involved with multi-fragmented fracture. We can name on a X-ray also, it is unstable variety. And this is another fracture where we call the reverse oblique type of a fracture, where it is a fracture which is at the level of the lesser trochanter. It is a transtrochanteric fracture, maybe transverse obliques or comminuted fracture. They are labeled as A3 fracture as a case of a unstable trochanteric fracture. Now, with this introduction, you can see here what is the biomechanics of intertrochanteric. The stability of an intertrochanteric fracture is defined by the amount of contact between the proximal and distal main fragment. So if it is a stable fracture, it's a reducible fracture, and there is a bone-to-bone contact between the fractured surfaces. Mostly a two-part fracture, one or two fragments can be reduced properly, and therefore the contact between the two fragments is best, and in that case we call it as a stable fracture. Loss of medial contact causes a varus collapse and shortening, and may also lead to implant failure. Instability occurs when more than 50% of the calcar is affected. 3 and 4 part fractures are unstable. Broken lateral trochanteric wall and reverse obliquity is another factor of instability. And higher the instability, more the difficult reduction, maintenance of the reduction as well as the selection of the implant is most difficult. So Kaur et al. Described 5 major factors related to the treatment outcome. That is, one is bone quality, fragment geometry, the quality of reduction, choice of implant, and placement of the implant in the femoral vein. So why? The choice of implant is also a very important factor in the treatment of the intertrochanteric. So what is why the intertrochanteric fracture fails? It's because of the deforming forces, not only the morphology of the fracture, but the deforming forces, they are working on the proximal femur, abductors, adductors, external rotator, and internal rotators. And the implant should nullify these forces, then and then we will be able to achieve a stable fixation. So objective of my presentation is now evidence-based protocol in the choice of implants and their indication in IT fracture. So evolution of implants in real modern era of internal fixation of hip fracture began with the Smith-Peterson nail in 1925. Smith-Peterson trifling nail with the detachable McLaughlin plate was introduced in 1935, was used to provide angular stability and rigidness to the constructs. And this is the trochanteric fracture treated by McLaughlin nail plate. In our student days and in residency, we used to perform this operation repeatedly because that was the only implant available to fix the fracture after traction. But what happens, there are so many, it's unstable construct because of the junctional zone instability, screw and plate screw, and therefore good to fair rebuild only can occur in a stable fracture, and in unstable fracture there is a failure of implant and loss of reduction because of lack of control over the stability, and therefore this implant was discarded way back in 1960. So the Jewett nail plate come introduced by a fixed angle one-piece metal plate to provide angular stability of a fracture fragment, and early mobilization in 1930, and it was extensively used till to near about 1980, indicated in IT fracture. And these are all publications where it is just a principle is a single implant, very robust and rigid implant, and it can be inserted over the guide wire like a DHS. Only thing is that it has a tri-flange with a pointed end, and there was a problem of penetration into the hip joint and does not allow impaction, hence cut through an implant breakage was the more common, and therefore some modification were also done, and this implant are also discarded. So then currently used extramedullary implant is the most dynamic hip screw, trochanteric stabilization plate, 95-degree dynamic screw, and condylar blade plate. But most commonly used implant is a dynamic hip screw. Rationally of use of extramedullary implant, they are load-bearing devices, not a load sharing device. IM nail is a load sharing device. Implant is pre-stressed and put on the tension side of the fracture and does function as a tension device. Restoration of the medial cortical continuity is essential to reduce the concentration of stresses on the implant. Otherwise, implant failure is the result. Restoration of the medial cortex can be done by autologous cancellous bone graft or biological indirect reduction. With biological reduction, this implant can be used very well and bone grafting may not be required. But the most important here is the restoration of the medial cortical continuity. And therefore, in unstable trochanteric fracture, a posterior-medial cortical continuity is difficult to maintain in these fractures, and therefore DHS is not used in unstable trochanteric fracture. It gives excellent result only in a stable intertrochanteric fracture. So this is the rationale behind this fracture, and you can see the dynamic screw mostly now used in the basicervical fracture and stable intertrochanteric fracture. So DHS in the femoral head, sparing implant, sliding device that provide compression at the fracture site on weight bearing, permits early mobilization, thus reducing the systemic complication, less expensive than cephalomedullary implant. So what happens, there is an infection of the fracture occurs and therefore early healing. Dynamic screw in a stable fracture, 1995, 1951, Paul and Clausen in 1964. They have published their paper and they call it as a gold standard for stable ITG fracture. Sliding device that produces a compression at the fracture site is the on weight bearing and permits early mobilization is the most important advantage of the dynamic screw, and it is still considered to be the most commonly used implant in a intertrochanteric fracture. And these are all examples you can see here. This is a stable intertrochanteric fracture fixed by this thing. Some medialization has occurred, but the fracture has united. And you can see this is the fracture, three-part fracture fixed with the DHS. Fracture has united, some infection has occurred, but vulgarization and the fracture has united. So you get a number of, I used to do a number of cases with DHS with good result, but some limping may occur even after a perfect reduction and anatomical restoration because some sinking of the fracture does occur. So it is most commonly now used in a basic cervical fracture. Basic cervical fracture, it provides better mechanical strength under physiological loading and is better in cases with osteoporosis and significant displacement. And these are all examples of cervicobasal fracture. You can use one additional screw also to prevent rotation, but DHS gives excellent result in a cervical basal fracture with a one or two single derotation screw. So a happy outcome does not occur always. Fixation in unstable fracture by DHS, 14 to 20% in A2 fracture, near about 56% in A3 fracture. Main cause is a precarious lateral wall. So incipient lateral wall fracture is the main cause of failure after DHS. So then what to do? The surface implant are used with caution for unstable intertrochanteric fracture, and it's most decision important making whether to use an extramedullary implant or an intramedullary implant, but some modification like percutaneous compression plate or a locking plate and a buttress plate, they have been tried along with the DHS for, and they claim it as a giving a equal result, but all locking compression plates, they are used for proximal femur. They failed, therefore nobody now uses a locking compression plate, and a graphite percutaneous compression plate is not available with us, but they have produced a wonderful result in A2 type of fracture. It has a two smaller diameters. These are all compression screws, minimally invasive stay, lagging with the 9.3 and 7 mm diameters, and it gives a wonderful result, but it is not available in our country. Therefore, it is only futile to discuss on this thing. But a publication of a Grotfred said it works very well and prevents medialization in even an unstable trochanteric fracture. So these are all advantages are given of a Gottfried plate. I have no experience, but they said they are giving excellent result, fuel implant related complication and comparable surgical time, overall surgical cost are lower, and it results into excellent result. And in A2 fracture and in stable fracture, the results are more satisfying than DHS with additional screw. So but now in India, we can modify this technique of DHS to prevent medialization and to address the lateral wall. DHS with trochanteric stabilization plate, a modular component or inbuilt component you can get that buttresses the greater trochanter, prevent and reduce medial displacement in unstable trochanteric fracture, prevents telescoping of a lag screw within the plate barrel when the proximal head and neck fragment abuts the lateral plate, and therefore this is an implant which helps the various complications that occur of a medialization and reconstruction of the lateral wall. They are addressed by a DHS with a lateral buttress plate. So these are all examples: precacious lateral wall, DHS with trochanteric stabilization plus wonderful reconstruction of an unstable trochanteric fracture by DHS with a trochanteric buttress plate. This is commonly used, and those who are very apprehensive about using a intramedullary nail, they can use this implant very well. It's very easy a surgery. Just it requires some extension of a incision while doing a DHS surgery. These are all examples: lateral wall incompetence, fixation by this perfect healing. This is another example where PKSS is not detected on intraoperatively. This can be addressed. So whenever you do this is the fracture with a three-part fracture, it is better to keep with DHS a buttress device. This is a buttress plate because it helps in reconstruction of a rotator trochanter as well as prevents further complication of lateral wall and DHS medialization. So if you ask me today, what is the implant of choice if you are not doing intramedullary nailing in a A2 and an A3 fracture, A2-3 fracture, where the greater trochanter is involved and posterior medial fragment is also still involved. In that case, DHS along with the buttress plate reduces the complications. So, trochanteric stabilization plate adjuvant to limit the shaft medialization. Major collapse is prevented, but there are blood loss. It's a major open surgery, some complication, and increased length of rehabilitation. Otherwise, it gives a wonderful result. You can use, this is the plate. You can use the, these are one or two screws you can put into the greater trochanter. You can also use one of the derotation screw to add stability. So there are some permission and combination are there, but I think this is a good method of reconstructing a damaged lateral wall. Another implant that is extramedullary implant, condylar blade in IT fracture. In 1977, Muller et al. Group devised a condylar blade plate, a static implant, which considerably increased the stability of the construct and most robust implant. And you can reduce this fracture, open anatomical reduction. And once this fits into the fracture site, the loss of reduction is not possible unless there is some breakage or a failure of implant. So these are all examples. You can see this is a three-part, four-part fracture can be addressed with the condylar blade plate. So what is this condylar blade plate? Plate is placed on the lateral side. Already in the last week, we have discussed about it. And it works like a Gottfried plate. It prevents the proximal femoral head rotation, and compression of the fragment can be achieved by putting the Muller's device. So these are all high subtrochanteric fracture. But ideal indication today, if you ask me, of such a fracture is an intramedullary device because it's a minimally invasive surgery. Though I like a condylar blade plate in such type of a fracture, I use only in an unreducible fracture by closed method. And when I have to open it and then I use a condylar blade plate. Otherwise, if I get a reduction and perfect anatomical restoration by closed method, I always prefer intramedullary nail. So these are all example. Irreducible fracture requires open reduction and perfect anatomical restoration. So as I said, the main cause of failure of is the lateral wall and progressive varus, and these are all complications described of a surface implant, and therefore they are all examples where stable fracture converted into unstable fracture. And therefore, some of the authors, they have tried in 1970s Ender's nail, a condylocephallic nailing with a bundle of suplap nail providing a temporary mechanical solution and early weight bearing. This method was received with much enthusiasm in 1970s. Many proximal femoral fracture were treated with this ender, but it was eventually replaced by a intramedullary because of loss of reduction, migration, proximal and distal migration, loosening, and there were so many complications of a ender's nail, and therefore this device is, though many people in Gujarat they use it, but I am I am all over world, this implant is not used for unstable intertrochanter. So things change. Healing is no longer a success. Deformity and function matter. Priority insult counts. And in such a situation, now the world is switching from the extramedullary implant towards the intramedullary implants. And there is an article in journal in 2012 or 13, I think. It is in the British Journal of Orthopaedic. How the people are now, this is the extramedullary implant, this is intramedullary, and over the years, now the use of intramedullary implant has tremendously increased. And if you see the graph, probably it will be like this. It will be intramedullary and this will be extramedullary. A variety of IM nails have been devised to achieve a stable fixation. Most popular implant was gamma nail, and then PFN, PFNA2, two screw, single screw, and now we get a PFNA screw, ZNN. There are so many modifications are available. Now, why? This is most important. This is a surgeon control factor. Choice of implant is the intramedullary implant in present scenario in an unstable trochanteric fracture. Why? It is because of the mechanical advantage. Mechanical advantage of the intramedullary device or extramedullary device. So there are various devices are now used. So why the IM nail is preferred implant in unstable trochanteric fracture? It is because it allows the temporarily mechanically incompetent but biologically viable fragment to heal around the nail. These are all fragments if the proximal and distally there is a stable fixation. Biomechanical almost all load is transferred to the nail and negligible portion to the femur side. In extramedullary implant, the whole load is on the medial cortex. Here, the load is taken by the intramedullary implant. So what will happen? Successful treatment restores medial cortex by secondary bone. It's because there is no varus load over the fracture. The implant takes the load, and therefore everything heals, and even medial cortical support that was fractured, it also heals very well because the nail compensates for the posterior-medial wall. The first implant, that is gamma nail, the Haldar in 1992 has introduced and published also, and he has given a wonderful result. There was a 6-degree angle at this juncture. They were used to put from the lateral entry point. Then modification was done. A short gamma nail, this is asiapacific nail, were used where the medial entry point was given. So these are all modification in that gamma nail were also done. On all the modifications that are all available of a single screw in the market, it is just nothing but the modification of a prototype of a gamma nail. But what is a single screw is unable to resist the element of torque. Minimum 2 screws are required, and therefore EOASI proximal femoral nail was devised in 1996 with the 2 screws. And you can see here, this is the 16.5 or 17 diameter. This is 11. This is 6.7. And in Indian market now, it is 8.2, 6.5, and it is a 16.5. So it's a dynamic class implant. It allows some collapse, but it limits the collapse, and it can be locked dynamically or statically. A most popular implant, modified and extensively popularized by Dr. B. Shankar and me since 2001. And we have performed number of workshops for PFN, a newly designed Indian version of a PFN, and it was developed by combining the sliding hip screw and intramedullary system. And you can see here the diameter was reduced to 15 mm and 8 mm screw. This is a cervical screw. 6.5 mm is the this is the derotation screw. A device can be locked. This dynamic and static, and length is 24 to 25 centimeter, and that was the previously nail available all over the market. And then what has happened? These are all results of PFN is a dynamic, it allows limited collapse, and also it compensates for the posteromedial fragments. A wonderful implant. Some collapse may occur, but it limits the collapse by the intramedullary implant. So these are all features are very good, and they were very conducive for the union of fracture. It's because it's a minimal invasive surgery, and in implant itself acts as a buttress to prevent excessive fracture collapse. This is the buttressing effect you can see here. So the nail cannot go inside here, whereas DHS can go from this because of the collapse of the fracture. Here the collapse is prevented, shaft medialization is prevented. It's a minimum stress shielding device, and medial cortex heals. And there is a uniform loading over the femoral load over the screw from the cervical screw, derotation screw, and femoral head. So there is a distribution of the forces over the nail and a screw complex, and therefore failure is minimized, and it was favored by many that this is one of the best implant. So positive reduction and correct entry point gives an excellent result, but subsequently because of the not a very good surgery, and it is a procedure wise surgical error. There were so many complications of true screw system, and therefore now this has also gone into disrepute. So it's because of not because of the implant, because of the fracture pattern and surgical errors. So proximal femoral nail, an analysis of 100 cases, approximately 1 year for I have published this paper in 2007 in International Orthopaedic. Those who are interested, they can go through this article, which is published way back in 2007. So another article I published, because that article, that is the nail is now, this is a 24, 25 centimeter. It was hitting the lateral cortex. And therefore, when bowed and dart female, it was very difficult to negotiate this. And therefore, that time a long PFN were not available, and it was producing some fracture, some thigh pain because of the abating of the lateral cortex. And therefore, what I did a modification in the proximal femoral nail, and that is a short proximal femoral nail fixation in intertrochanteric fracture. And this paper also I published way back in the 2010. Whatever the short femoral, proximal femoral modification they came, I am the first person to do a modification, and already this paper is published in the journal in 2012, where I reduced the diameter, 18 centimeter nail, 8 mm cervical screw, and 6.5 mm stabilizing screw can be locked distally and dynamically, statically. And this is the implant which is available all over the India. And I am the person who has not this, what we can say it is, I have not done that,
Patent.
that patent is,
Patent.
and therefore, this is now it is called everybody's luck. And if I would have patented this fracture, in way back I used from 2017, and I published this paper in a foreign journal. So this is how it is, the story. It's a very small trochanteric assembly aiming device, and it's a very minimal invasive surgery where you put the nail, and proximal and distal locking can be done through a single incision. So it's a very minimally invasive surgery, matters in the intertrochanteric fracture because it prevents fracture hematoma and everything heals around the nail if there is a stable fixation. And these are all examples. These are very bad. Maybe these are the picture from 2006 or 2005, I think so. So, but unstable intertrochanteric fracture, this is in a 70-year-old lady. Though choice of fixation is PFN, but you can see here, these are all if the fracture is not reduced properly, if there is a negative balance, there is no proper entry point, then it fails. So migration of screw and progressive failure because of unstable construct is the main problem of a two-screw system. And therefore, how it fails? Sliding screw nail, nail in the center of the femoral axis, reduction of the lever arm, no neutralization on tensile side, sintering into varus and cutting through. That time before 2015, nobody was bothering about this lateral wall implicated in the management of intertrochanteric fracture. Still, Westerner feel that the lateral wall does not give much problem in intramedullary nailing. But over the years of our experience, it said the lateral wall is the main culprit in failure of intertrochanteric fracture, whether you use a extramedullary implant or intramedullary implant. So then came a implant because the two-screw system provides unstable construction osteoporotic bone and migration was the rule. And therefore, PFNA was introduced in 2003 and utilizes a helical blade instead of a conventionally used two screws. PFNA with helical blade in an osteoporotic bone because that is a dynamic class. This is an impaction class and therefore it impacts the bone and there is bone preserving implant. So positive medial cortical support and valgus reduction gives excellent result in a osteoporotic bones by a single screw also, but it is a bone preserving implant. Initial results were very good. Reported results were compared to the PFN system. And then ultimately, the philosophy and rationale was a blade compacts a cancellous bone and improves hold in a osteoporotic bone. This is the screw holes of a PFN where a screw system is used. Whereas if the blade system is used, you can see there is a compaction of bone around the blade. Here is the loose bone. So helical blade believed to provide stability, compression, as well as rotational control of the fracture. And therefore, it was also extensively used, but problems were intra-articular migration and varus collapse. These were the complication, therefore, and then PFN2 offers no significant benefits for PFN in terms of postoperative complication. So cutout is common in both. So initial euphoria of using a PFN, gradually it has disappeared. And then you can see the PFN2 is a static implant. PFN is a dynamic implant. It allows some collapse. Migration of the screw is more common, whereas intra-articular migration is more common in a PFN2. Migration, lateral migration is more common in a PFN. So no significant difference in terms of cutout, cut through between two groups in their study, and therefore the choice of implant in osteoporotic bone, still it is a PFN2, where because it compacts the bone, but equal literature says there is no difference. But if you give me a choice, I will use a PFN2 in a osteoporotic bone and a well-reduced fracture. So treatment option in a unstable trochanteric fracture, screw or helical proximal femoral nail. So now the screw is also available instead of a blade. So both screw and helical blade PFN are effective implants in osteoporotic. So there is no difference whether you use a screw, single screw, or a helical blade. So the same system is available. You can use a PFN helical blade, or also you can use a screw, whichever is best possible, but results are equal, but there is a difference between the screw. Screw is more costlier than the helical blade. Now another system which is now coming is intertan nail, or this is known as integrated system. Compression is achieved and maintenance in unstable osteoporotic bone, and it works on the worm gear mechanism in osteoporosis. And you can see here how the collapse occurs, where the compression can be achieved. So lateral compression can be achieved, and if there is no lateral wall also, this system can be used because it holds the fragment. You can see here. So another example you can see, this is the trapezoid design of the nail, therefore migration is prevented. Small proximal diameter and integrated interlocking screw system. 12 degree of a built-in femoral neck anteversion, already it is there, and flow tip, distal tip. So there are so many advantages are described in the literature, and you can see how they pushes the shaft towards the femoral head, and therefore lateral wall is not required for compression in this system. So optional is a linear compression, and where in the PFN 2 screw system we required intact lateral wall to compress the fracture. Here the intact lateral wall is not required to compress the fracture. So this is this is how it is. You can see here, and you can convert this system, allowing you just convert into a dynamic system into a static system. This system now it is available in PFN 2 screw, helical blade also. And now this is even available for the 2 screw system also. So you can convert the dynamic class into a static class. So this is an example. Compression is achieved, maintenance of unstable osteoporotic fracture, perfect healing of fracture, valgus reduction, even in the lateral wall. Another example you can see here, pre-op, relatively stable fracture, worm gear mechanism, lateral wall is gone, still the fracture has perfectly united. Now another system has come. It is just a modification. Instead of a PFN, a helical blade, we have to use a screw system, and there is angle is 4 degree, and there may be a inbuilt anteversion. So next generation hip nail that addresses a remaining shortening of current system consists of a series of cannulated screw and nail, cannulated end cap, and locking block. These are all new modifications are coming up. There is no special advantage as such. It is only the cost provoking. This cost more costlier than the simple screw system, and it is just an additional burden to the patient because there is no differences between 2 screw system, single screw system, PFN helical blade, or even an integrated screw system. So whichever the best method you perform, and in your practice, that is the best for you. But the most important is the valgus anatomical reduction and stable fixation. And in osteoporotic, this is described, the cement augmentation to prevent migration. I have not done it. People may be doing it to prevent, to create a stable fixation. So now this is a new implant is coming up in the market. Some of the I have done 1 or 2 cases only. Heliflex nail was developed by Dr. Haldar in 2013. He has devised gamma nail in 1992 and in Heliflex nail in 2013 to treat the extracapsular fracture by close reduction fixation. This implant is called as a Heliflex nail. There is a set of tri-wire So the wires are passed to the cannulation of this nail and they just push inside the femoral head. So when they go along with the screw, this is the screw system. There are 2-3 wires are going inside and it provides a rotational stability, which is so important in osteoporotic unstable trochanteric fracture. You can see here, these are the 3 screws, one going superiorly, one going inferiorly, and one going posteriorly. So these are tri-wire incorporated inside the lag screw to provide the additional screw. And I have no much experience. I have done probably 1 or 2 cases only, but it's a very easy surgery. It looks difficult, but it's a very easy surgery. Just do a PFN surgery like this, and there are tri-wire. There is some instrument is there. Just we have to push it, and it goes inside. So trochanteric fixation nail, telescoping lab, self-contained collapse with the lag screw prevents lateral lag irritation. So this is now modern system is available. Instead of a PFN, 2 helical blade, a trochanteric fixation nail with the screw, and these are all very site specifics are also available. You can get right and left because some anti-version inbuilt is given, and there is a bend also, so that it gives anatomical fixation. So these are all modifications are there. But if you do all types of fracture, lateral wall is gone, then we have to lateral wall address by my thinking is by screw. You can use a Gonzalez plate, or you can use a trochanteric buttress plate like this, so that you additionally nail and plate combination, not only in failure, but you can use in the primary also to prevent subsequent failure of the implants. So in summary, stable IT fracture, DHS, lateral wall involvement, DHS with TAP if you are so fond of extramedullary implants. Unstable IT fractures, IM nail, PFN single or double screw, it is your choice. For osteoporotic fracture, PFNA 2 with additional screw. Floating lateral wall, IM nail with augmentation. You may augment with the wire, you may augment with the plate, you may augment with the additional screw, or you may add weight with the hook plate. When nothing works, is the replacement is the choice. So in summary again, stable DHS, lateral wall involvement, DHS with TSP, unstable IT IM nail, osteoporotic bone PFNA2, floating lateral wall, nail with augmentation, and when nothing works, replacement. So take home message. Ultimately, newer designs of implants are not panacea to prevent complication. Valgus reduction, anteromedial reduction, lateral wall stabilization, and minimally invasive surgery is the crux of success. If the current evidence is conflicting and does not always support the treatment modality that are widely used in practice, such as extramedullary implant in proximal femoral fracture, the technique and implant continue to be modified, making the older literature less relevant to current practice. So, the choice of implant in your practice should be, these are all, and those implants you can handle very well. You can do a valgus reduction, anatomical reduction by close or open method, then fixation easy, implants are immaterial. On clinical studies, the DHS and the PFN in a stable fracture results are equal. In unstable fracture, intramedullary nail scores over the extramedullary implants. But in a lateral wall fracture, combination of the extramedullary plus lateral wall support, intramedullary with the lateral wall support is the crux of success, along with the perfect parameters. They are quoted in literature, should be followed. It should be a positive reduction and perfect placement of the implant in unstable trochanteric fracture. This is how it is. Thank you very much. So anybody wants to ask the question, they are free to do so. I am here to answer you all, and there is nothing you can see here. So
Thank
Tanna
you, sir. Thank you, Gadegune, sir. Wonderful synopsis of all the implants available, both intramedullary as well as extramedullary. If you please stop your screen, please unshare your screen.
So,
Stop
no.
sharing.
Sir, one question, sir.
Yeah, go ahead.
Yes.
Sir, do you use a small nail or long PFN, sir, in extracapsular?
The extracapsular fracture stable at the trochanteric level, it does not matter whether you use long or short. In a high subtrochanteric fracture and in subtrochanteric fracture, long PFN is the choice of implant. For a intertrochanteric fracture at the lesser trochanteric river, whether you use a short or long, it does not matter very much, and it has been proved beyond doubt in literature also. But in subtrochanteric fracture, it is always and always a long PFN.
Okay,
However,
thank you,
what,
sir.
what I would like to add there is, occasionally when you try to use a long and femur has more bowing, then a short version is possibly better in that case.
Exactly, sir.
Yeah. Any other question? Please go ahead.
Sir, I have been presented one DHS with the TSP. That result is okay, sir?
Yeah,
Yes.
that's fantastic. You presented a whole series. Would you like to
Yeah,
present? Would you like to present how your results?
yeah.
If it is ready, you can share screen and present.
I don't have ready, sir. Last in this group I was presented, sir, last week.
Yeah. All have gone through that, and they are
Yes, sir.
very good. You have augmented the DHS with TSP very nicely.
Yes.
And I suppose there is a TSP which is custom made as well.
Yes, sir.
Yeah.
Thank you, sir.
Any other question?
Sir, when use angle blade plate?
Angle blade plate is not a very popular implant last 50 years. But we are now, I am only using when I am not able to do a close reduction in an unstable trochanteric fracture. And then if I want to open the fracture, why not to do a condylar blade plate? That was the idea. But to my mind, in my hand, condylar blade works wonders. So now after having done a 50 cases, probably I may write an article, but still if you ask me, PFN is my first choice and the second choice is a condylar.
Okay.
So answering that question, the gold standard role of angle blade plate is reconstructive orthopedic surgery, especially when there is a previous implant and the head and femoral neck is violated with the available bone. As angle blade plate does not take up any bone out, that's a preferred implant in such revision scenario. That is one. Reverse oblique also is a very good indication for angle blade plate. However, the best indication is a non-union scenario, very unstable fracture, where lateral wall implications are there and where trochanteric entry point implications are there. That is where we can use the angle blade plate. So out of 100, maybe 2 or 3 cases would be the best indication for angle blade plate, not all. And one thing we have to remember that it's a complete open procedure. So when a closed procedure is available, which can give equally good result, I think most of us would follow a closed procedure. Any other
One question, sir. One
Any-
question for
Any experience on bone cementing, sir? That sir showed in one case.
Actually, Done it. Chandak sir must have tried.
Yeah, I had done only one index case and did not find many great advantage of the procedure. Secondly, you're always worried if there is a break or at the tip, if there is perforation, and if it goes into the joint, that is another thing. And third, it requires amount of pressure. And fourth, you have to use only that specific implant company's device. You can't use it with any other device.
And that is also a very costly device.
And costly device. So the whole thing, 80,000 for an Indian patient becomes exorbitant almost.
Sir, you were explaining in infected you use no, with cement and some vancomycin.
Yeah. So that
Well,
is,
what is rational?
so the rationale is antibiotic elution in the closed space surrounding the fracture and infected zone. When antibiotic elution is there in high concentration, even if bacteria are resistant, still we are able to get a good infection control. So you can use a PF nail, that is PFN, which is coated with antibiotic, and then you can use it. Also, I would use extra osseous mantle of cement in the form of hemicylinders to control infection. And I would be sharing cases where I have used that as well.
Thank you.
If you like, I can share a case even right now also.
Sir, share the case. You can share the cases 2, 3.
Yeah, I'll share. By the time you can take up the questions, I'll just bring out the case. Any other question? Somebody had asked question. I think we can go ahead with that.
Sir, what is the choice of implant in any failed surgery? Are there any? What are your protocols, sir? If you do, if what if DHS fails, and what if iron nail fails?
If DHS fail, it depends. Actually, after the why DHS failed, actually, if the trochanter combination is there, what is if the shaft problems are there, we have to study that, and depending on that, we can use the implant. That is straight away, you cannot say remove DHS and do a PFN surgery or condylar plate surgery. So what structure has been damaged by that previous surgery, and what you want to reconstruct anatomically, then and then we can add the implant. So it is, we cannot say blindly that suppose the PFN is removed and you can do a DHS or condylar plate. It's not like that.
Okay, sir.
Sir, if any excessive curved shaft femur having subtrochanteric fracture, what is the price of implant?
Excessively bored trochanteric fracture, you can use a long PFN with a there is long PFN, not straight. It should be a curved PFN. The narrow PFN you can use it, or a very short PFN, 18 centimeter. So you have to judge where it crosses. If the bowing is after the 18 centimeter, then you can use very well the 18 centimeter or 17 centimeter implant. There is no issue. But if the bowing is higher,
can we use long DHS in case of subtrochanteric fracture?
why cannot? Why reduction and implant selection is not a very difficult problem, but the long DHS surgery, it's a very exhaustive open surgery, chances of infection, there is a still chance of lateral valve violation. Therefore, in a subtrochanteric fracture, DHS was tried before. The results are inferior to the closed PFN surgery.
Thank you, sir.
Sir, in IT, diameter of the nail matter, whether it should be well fixed or it should be 11 or 12. Does it matter in IT?
It matters. Because if it is a loose one, what will happen? Your mediolateral screw will also translate. So it should be relatively a stable fixation in the trochanter as well as into the medullary cavity. It's not a press fit, but it shows a stable intramedullary occupying structure. Suppose the canal is 12, you may use 11 or 10, but you cannot use 9 like this.
Yes. Do you ream it or just proximal entry only?
Proximal entry we ream, mostly it's unream technique, but if the canal is very narrow, it is a 9 mm, 10 mm, that we should put a 10 mm rod, otherwise it will break. In that case, only the femoral shaft reaming is required. Otherwise, majority of the cases, these are all osteoporotic old patients. They do not require a femoral reaming.
So Gadegone sir, can I share my screen now?
Yes, sir. Yes, sir.
Okay.
Any difference in the embolism in IM cases, intramedullary devices versus extramedullary?
Actually, embolism, there is no comparative study, but it may occur and the incidence is 0.02%. But in my practice, I get very rarely.
Do you use a low molecular heparin?
No, I don't use it unless there is an indication.
Thank you.
So Rakesh, the question is fat embolism or venous pulmonary embolism?
No, venous pulmonary.
So venous pulmonary embolism, the consensus is always to give prophylaxis. So thromboprophylaxis is an established procedure, and if you don't give, legally it is not safe. So whether giving thromboprophylaxis would lead to hematoma and further deterioration in wound condition, that is what you have to assess. So all patients with comorbidities, definitely thromboprophylaxis. Maybe 12 hours to 24 hours post-op would be a standard regime. And we can't escape the legal implications if you don't start thromboprophylaxis. What LMWH to start is your choice. You can use Fragmin, you can use Clixen, whatever it is. As a practical purpose, what I do is I start the LMWH, discuss with relatives and physician, and if he says continue, then we continue. In case he says, okay, switch on to either Ecosprin or a oral molecule, then we switch to oral molecule. But I think it's an established thing. And in my practice, I do use thromboprophylaxis regularly.
Is important. It does not matter whether you are doing DHS or intramedullary. It does not matter.
It does not matter because it is the virtue of STRIDE is recumbency, problem in the venous wall, and sluggish flow. So all three things are there in a fracture neck femur or all proximal femur interventions. So you have to use it ideally. Many
Yes.
centers may not use it. You can use your judgment. If patient is mobilized next day and he's doing well, still my worry is those patients who go home and then suddenly develop a embolism, they get admitted with a physician, and then he labels that you have not given thromboprophylaxis or he was not on that, and that is a worry. So
Now-
yes, ideally yes.
Now I think the cases are rising. Now we are seeing more or more cases.
Yeah. So there are few practical hints or practical tips to reduce thromboembolism. That is ankle pumps and using the DVT prevention devices, to adequate hydration, avoid recumbency. So all those things I think all of us must be employing.
Yes.
Yeah.
Thank you.
So it is a very vast topic. There are so many controversies also. And I think
I do agree, sir. Totally agree. Totally agreed. And therefore, you have to take a call. You have to, and if you are not using, you can write down on paper that risk assessment done. And in view of our early mobilization, and as patient is mobilized on day 2, we are not using thromboprophylaxis. However, be watchful on discharge, advise venous Doppler, and then you can follow up and refer to physician if there is any problem. I think a safety has to be inbuilt in our philosophies.
We should document it. But documentation is very important to
Very
protect you.
important. Yes, yes.
Thank you.
Nowadays, patients, relatives do not take it easy, and so we have to be on the right academic front at least. Whether you use it or not in every patient is your choice, as your clinical judgment is of paramount importance.
So just question to Gadigona sir, why he's not using? Any worry to bleed or some cost is the issue?
It's not a worry, but in my practice, after so many years, I have not used it and I have no regret also. 1 or 2 cases that even after doing a prophylaxis also, they do it, but there are so many other complications of prophylaxis also. It takes a longer time to heal, bleeding and everything. And I am mostly treat the village patient mostly. And the treatment should be actually practical as well as it should be affordable, and patient also should take it properly. So there are so many issues with me, and therefore I don't use it. That does not mean that I don't agree with Chandak sir. Standard protocol is use a prophylaxis. Whether you use it or not, that is your
individual choice. Yes, absolutely agree, sir. Any other question, or should I present
You
something?
can continue, sir. Continue.
I can continue. So the question asked was, if there is a failure in intertrochanteric fracture, how to revise and what should be the philosophy of revision? So revision fixation of a fracture neck femur is required in many situations. So this was a patient who had a DHS fixation. It was 4-hole, 5-hole plate, and within second to third week, there was an utter failure of the fixation. And when we analyze this patient, his X-ray, can somebody comment on this X-ray? You are able to see this full screen? You are able to see the screen?
Yes, sir, we can see.
Yeah.
Yes, yes,
So
we can.
you can see my cursor and just look at
Yes.
this X-ray. Can somebody point out what was the cause of utter failure in the second or third weeks itself? Look at the
Reduction is not approved.
So this could be one, but on day one it was all
Sir.
well. Yeah.
Sir, the
Lateral screw
screw
may be
and
out.
sir, they are at the fracture side, sir.
Okay. So you feel the
It must be subtrochanteric fracture as well.
Okay. Yes, that also. So all things accepted, but look at this finding. Can you see this?
Who is very superior?
Acetabulum.
So there was a loser zone and his vitamin D was negligible, just 1 or 2. So I think that patient suffered this mishap. Just one of the reasons could be osteomalacia, which was existing in the patient, and his vitamin D was almost not affordable. 2 was a very, very, very insufficient value, and that was revised. So now when there is a failure of a surface fixation, usually by and large, my philosophy is then we provide an intramedullary fixation. And when usually intramedullary fixation fails, a surface implant is one of the components of the fixation. His usual strategy may not be 100% true. And that was fixed with this device along with the metabolic enrichment, and that patient did well. So a non-union revision in intertrochanteric is required in many situations. And the situations are, of course, non-union, even out of bone placement. As you can look at this patient had a DHS fixation and the DHS screw was out of the head itself. So there also it required revision. When there is an implant cutout, as is happening in this patient, then also you need a revision. Penetration of articular surface. So everything else is fine, but articular surface penetration, as was pointed out by Gadugani sir, either a Jewett nail plate or a PFNA, whatever it is, if it is cutting out, but it is still holding, we have to revise it. Subsequent lower fractures also you have to revise it, and implant failure also you have to revise it. So these are the usual indications. Now we take up this case. This case is similar to a case which is presented in the Jacobson's paper, which brought out the importance of the lateral wall. And as you can see, this is one unstable fracture where DHS possibly is not a good device. And here you have to either put a TSP. Remember this X-ray, very, very nice X-ray as brought out in the Jacobson paper. So whenever you have such a situation, always, if you are using a DHS, always supplement. Can we do something at this moment? Yes, couple of patients we have revised. At this point itself, maintaining the screw if it is in good position by adding a TSP if the patient is reported within a month or 2 of his initial fixation. But when it is not done in time, this is all disaster. Everything gives way. If the bone metabolism is not good, there is a devastation. Now, how do we plan revision surgeries in intertrochanteric non-union? Or for that matter, even in the intracapsular non-union? You need to plan for extra time. So it is the standalone first case. you need to have all rescue instrument of either implant retrieval or drilling a difficult bone, drill bits of various sizes. Usual my policy is whenever I'm revising a case, I'll change my drill bit to a new one, usually. And blood and extra anesthesia time, you need to plan. And graft, ideally I harvest the grafts before I am embarking on the fracture so that it reduces that amount of hemorrhage which is happening from the open wound. And this planning also is very important. You plan whether the femoral head is viable, and that is usually a clinical judgment. As in all these cases, you can revise by various means. And implant selection is really important. What implant to use? Now, how do we choose what implant to use? Now, if there is a complete erosion on the superior part, so you need to take an implant which would hold into the lower segment. If this part is eroded, the superior part of the head and neck, then your obvious implant would not be again intramedullary. You have to have hold somewhere here. So angle blade plate would be a very good device, or a DHS where it goes onto the lower segment. So that way you have to choose your device as was done in this case, and the void is then filled up with the graft. And when a device like an intramedullary has given way, then you can take out the intramedullary device, give traction, assess, and then either you put a DHS with a TSP or an angle blade plate is a suitable device. So this is how it is decided. So this fracture was a very difficult situation for me to manage. So it was intertrochanteric fracture. Patient had infection. So orthoplasty was ruled out. And this patient was a manual laborer. So I had to do something, even though the head looked almost avascular with almost 50% head gone. I had taken a decision of giving him a femoral head. Now this patient is almost 17 years post-surgery, but that is a very exclusive, rare situation where you are putting the implant into a zone which is yet not violated, where it can give you purchase using bone graft. And this was a rare situation where I had to embark on this surgery. Now, if this is the situation and where the whole cartilage, etc., is gone, nothing else but a good orthoplasty would be the solution. So, implant selection in a redo is really very important. And whenever there is a cutout, so cutout you have to study where is the cutout, what sector of bone is available where you can have purchase, and that is the main thing in deciding how do we choose implant. So you have to choose implant according to the available zone of fixation. So this was a patient who had a PFN fixation. So that was possibly not the good choice. This had come after his fixation, and proximally it had now cut out. Now study this. How do you choose? This was a basal intertrochanteric. So now anything which gives you fixation here. Now if you take an angle blade plate, the problem with angle blade plate would be you will be fixing it here, and then how much amount of osteotomy you are going to do would be difficult to calculate. So I did not choose angle blade plate, rather I preferred a DHS. And you can look at it. DHS is one implant which has all varieties of angle available, which is not a choice in PFN or in the angle blade plate or PFN. So DHS is an implant where angle variability is your biggest mantra. Whatever angle you want to do, you can do, right from 120 to even 150. So you have this angle variation. And here, as you can see, this was done with a DHS at a lower side and a fibular graft, and that had given a wonderful result. Now, this patient was DHS and had a chronic renal failure or chronic renal insufficiency, and was revised with angle blade plate. Even after revision, the bone metabolism was not up to standard. However, the patient healed and become asymptomatic, but the amount of virus remained. And now if I reflect back, what happened? This was my very, very early case. Now, so this angle chosen should have been from this point to lower in the femoral head. That would have given me more valgus, or possibly I did not do valgus osteotomy in this case. just because the chronic renal failure was there. We wanted to do a quick surgery. Apart from that, the fracture healed and gave the required result for the patient. But the choice of implant when a DHS failed in this situation, angle blade plate gives you all the flexibility so that your anchorage is into this part. So you have to choose the device according to the anchorage obtained. Now this patient came after a failure of a PFN, and this where the entry point is totally violated. So now look at here. And again, this was a farmer not ready for any orthoplasty, and orthoplasty itself would have been very difficult, would have required a very good implant. So the zone of availability here is this zone, and where an angle blade plate can take a very good purchase. So that was done with a angle blade plate. So if this was a patient who had come after first surgery as DHS, then there was a PFN, and the whole intramedullary position was blocked with multiple broken screws. Now, if you need to revise this fracture, you need to think about. But the primary thing, what is required in this case is the interfragmentary management. So this is the zone which you need to manage. Here you have everything available to manage whatever way you would like to devise this. So plan and judge what thing is available, and accordingly where you are going to get the best result. Plan your fibula, get a fibula harvested as per need of the patient. Either you can harvest on patients in situ, split fibula or whole fibula, and then you can mill it according to the requirement. And these are my various tricks of managing fibula. This was the old SP nail starter. The shape of this is exactly like a fibula. So when you are hammering a fibula, this is very useful. And when we impact fibula, bevel it becomes easier, so that the joint penetration is also reduced, and you can place the fibula where you exactly want it. So these are the various methodologies how you can place fibula nicely. This was split fibula. This is double fibula in an intercapsular neck femur. So during the guide wire, you need to monitor them because the bone is very porotic. So you need to place the guide wire. So I usually would like it onto the lower half of the femoral head once there was a previous migration of the implant. And then this is my preferred zone where I would plan a DHS and then a subtrochanteric osteotomy, even in an intertrochanteric fracture if it is not doing well. This is a common situation if you are using a DHS for a lower fracture and a reverse oblique fracture. So this can be best managed by either a TSP or an intramedullary nail device. But this is another very good indication for an angle blade plate. So if required to revise this, I would revise with the angle blade plate. Reverse oblique and a non-union, that would be the best situation. Whether you use circlage wire, etc., to primarily reduce the fracture, it is your choice. So this is the preoperative plan when I would do a angle blade plate fixation for a non-union, subtrochanteric non-union. And angle blade plate use is not actually that difficult. You just need to plan it out well. And the anchorage you have to remember very nicely. Where is the anchorage? So on the curvature of GT, you are not going to put it. It is at the base of the greater trochanter, and you are into the inferior segment of head. And this gives the, for the 95 degree, it gives the best anchorage, and is not difficult to practice like this patient. Now, we discuss here what implant to use. So if we can interact on this X-ray, so this is not an uncommon situation for a PFN. Usually it breaks at this point with PFN or even with our old devices. Breakage was at this point. So what one would like to use here? Any comments? Anyone who would like to comment on this? Gadegone sir, your choice would be?
I will use this. In this case, I will remove this. Again, probably I can redo the PFN with the trochanteric buttress plate. But today, after having done so many condylar plate, I will do a condylar plate with or without bone graft.
Okay. So as sir has suggested, so this is a condylar blade plate which is going on to two guide wires so that we don't go haywire, we don't go higher up, and then get the right angle. So this was revised with a uh, with a angle blade plate. Here I should have used with 5 mm more of blade, but that patient healed well. I do agree around 5 more degrees or 10 more degrees of valgus could have been achieved. Possibly, I tried to do a open reduction and interfixation rather than a osteotomy. That could have been a lacuna in this case, but patient healed and did well. So this was a young boy where this area is already gone. So again, two choices. You can put a angle blade plate that would be around, or you can use an angle blade plate with an entry at this point of 120 degree and then give a valgus osteotomy, or use a DHS and then do osteotomy. Both devices are possible in this situation. So this is the way I would like to plan. This was a patient who had come after surgery. Patient had pain persistently. And as you can see, the screw placement was almost like half screw out of the place. And that was revised with again DHS. So surgeon thought at this point of time the fracture has healed and he removed the implant, but actually that was a non-union. And then again it was uh, fixed with a DHS. So to me, DHS is a good device in fixing. Angle blade plate is a good device for revision. And when the DHS fails, angle blade plate or an intermedullary device also is a good choice. So these are the various ways we can manage an intertrochanteric failure. Any questions at this point? I would just interact at this point of time. So that patient was a very difficult case for me. So everything gone and patient not willing for revision surgery. So we managed with a angle blade plate. There was no, as you can see here, there is nothing for angle blade plate starting point. So we managed with this, and is such a happy patient. Is almost post surgery more than 10 or 15 years, doing well. I do agree that not the right amount of valgus osteotomy was done in this patient, because the bone available at this place was also not good. So we could not get 135 degree. I do agree it should have been still better, but that patient healed completely. So this was a patient where there was no neck at all, and that was reconstructed with double fibula, as you can see, it healed very nicely. So this was a patient who had a fixation with the DHS, but there was a large medial void, and as would be expected, this had given way. So that was also revised with graft and repeat placement. So at times in an intertrochanteric non-unions, giving the right sector of purchase, right choice of implant would give you a good result. So these are the various philosophies we use for intertrochanteric revision. Any comments, any questions? We can interact this point of time.
Conduct, sir, I think there is no set up rule after the in revision surgery in intertrochanteric fracture. So as
Yes.
we said, okay, there are so many modalities are available. We have to think over the problem, whether the trochanteric part is more violated or shaft part is more violated or fracture part is more
So,
violated. Accordingly, then the available implants, permission and combination is the rule, and it needs planning as well as a junior person should take a opinion of a senior person also, who is well versed with this. He will give a good functional outcome, because it is a open surgery. We have to redo the surgery. As he said, conduct surgery, blood is important, time consuming surgery, and less rewarding surgery as compared to the breast surgery.
yes, and I totally agree with you, sir, that we need to discuss with patient. It's a we need to sit on the X-ray, plan it out, and decide what we are going to do. Right.
Any difference between stainless steel and titanium implants?
I don't think anything matters. Whether whatever you use, whether it's stainless steel or titanium for revision surgery, the widest availability of implant is with the stainless steel. So my most common thing for revision surgery is stainless steel. And as we have we can maintain a good amount of our own inventory with stainless steel. If you are dependent on titanium, usually they are the loaner sets, and in revision, exact size is also very important. So to me, it doesn't matter.
MRI compatible.
Yes, MRI compatibility is not there, but most of the current MRI centers would undertake MRI with the stainless steel implant. However, there are scattering of the beams. But
Okay.
for any stainless steel, you can nowadays proceed with MRI of other region, not if of the same region. But that's a valid point if you want to go ahead with the MRI of the same region. If you are revising for an intercapsular and somebody advises what implant is used and can we do MRI, I think then titanium implant is a better choice. Yeah.
Thank you.
Chandak sir, now 10
Yeah.
o'clock. So I think
Any other question? Just if any other question is there, let us
before we
know.
wind up.
Yeah, no problem. If there is any other question,
Sir, take home message, why these things are getting failure, many of cases, why they're getting failure. In my experience, I'm sharing one example, sir.
yeah,
Before fixing the implant, they were not doing reduction, they were not getting proper reduction and fixing the implant. That is the only one of the thing is cases getting failure, I feel.
yeah. I think that's a very pertinent point.
Yeah, before fixing the implant, they have to get all the fragments reduction, proper reduction, and stable fixation is a key role for the success of the good result. I feel,
Yes.
sir.
Yes. So
Anything else, sir?
yeah, I think that's a very valid point, and I am sharing this case. Look at this case. So,
Sir.
what would be the choice of implant? You are seeing the screen?
Yes, sir. Yes, sir. Good able to see.
Yeah. So, what would be the choice of implant? I think DHS could be good.
I can go for DHS, sir, straight
Yeah.
away.
So straight away DHS could be good. No,
DHS.
yeah, DHS. So
With the
I'm
derotation
sharing the
screw.
With the derotation.
yeah, with a derotation screw. Now look
Yes.
at it. This case came from another state. So this was the surgery done. Now, as you said, if reduction is not there, no implant is going to hold, and if proper placement is not there, so there is nothing right here.
Yes.
Yeah. So this was a case also looking at this X-ray. This is one intertrochanteric fracture which has partial lesser trochanteric involvement. You should always be worried about
Yes.
the reduction, and this fracture always reduces in external rotation. So we have to set our eyes. And this case, this was no reduction. The placement was not good. Reduction was not good, and obviously it had to fail. And look at this case. So there has to be some reason whenever usually it fails. If only metabolic bone problems are such where even good implants can also fail. So this was a young patient with intertrochanteric fracture.
Choice of implant is wrong. DHS with derotation.
Yes. So here possibly we could have used a DHS, which would have given us a primary compression to the fracture site, better reduction. So
Exactly.
for fracture to heal, as Dr. Gadigone said, 5 gold standard things: good reduction, good choice of implant, good implant biology, good dissection. So 5 things you enumerated, Gadigone sir, and that was from Cross actually. That was wonderful slide. So if everything is right, then only, and that patient did not heal. So for me, my tray should always have a TSP. So if anything is going wrong intraoperatively, that should be available.
Exactly.
Right? Separate piece of calcar, separate piece of basal fracture, Again, rather than going for intertrochanteric and difficult reduction, I would go for open reduction, reduce everything properly, and then decide the things. So this is what I would prefer to do. So reduction is important. Right.
Thank you, sir.
So with this, that was wonderful. Radigone sir, thank you so much for today's good
Thank you, sir.
synopsis.
Thank you, sir.
Sir,
For nice.
it was very good. Yeah. Thank you so much. And we'll close down today's meeting. And next meeting will be obviously blessed that Tanna sir would be there. Yogesh, any questions from your side? Okay. Thank you so much. I think,
Thank you, sir. Thank you.
thank you so much.
Very good, sir. Thank you so much. Good night.
OrthoTV, we can close down today's meeting and you can stop transmission. Only one question remained unanswered. That was when to use 120-degree angle blade plate. So that I'll use for an intracapsular non-union.
Ali?